Hello future doctors, welcome back to episode 15 of our first aid series. So today we are diving into some high yield musculoskeletal conditions, that is bursitis and Baker's cyst and patellar fractures. These are frequently tested, and knowing the clinical presentation and management can score you easy points on your exam and help you in clinical practice also. So let's begin. So first, bursitis. So before going to bursitis, we have to know what is a bursa. Bursa is one of the synovial sac that reduces friction between the bones. Okay, so it's one of the synovial sac. It reduces friction between bones, tendons and ligaments at joints. Okay, so if you are seeing in first aid guide, it's wrote like this: the synovial sac that alleviates friction at bony prominences and ligamentous attachments. Okay, so they are found in exposed, pressure prone areas, making them vulnerable to acute injury or chronic irritation. Okay, so here why most commonly why we can see this type of bursitis and these things means because of chronic repetitive pressure and may become inflamed due to infections like septic bursitis and crystalline arthropathy. Okay, so it can cause gout and autoimmune conditions like rheumatoid arthritis. So common cause of bursitis is infection, that is septic bursitis, and most common organism is for causing bursitis, most common organism will be usually staph aureus. Okay, we will discuss this every microorganisms and bacteria and these things when we are discussing the first aid guide of microbiology. Okay, so next, crystalline arthropathy. This crystalline arthropathy can like gout and autoimmune conditions like rheumatoid arthritis. So what are the symptoms you can see in bursitis? Localized pain and tenderness. Okay, so swellings, erythema, especially in superficial bursa. Okay, more you can see in superficial bursa. Pain with active movements, but passive range of motion is often normal, a key exam clue. So in exam mostly they can focus in pain with acute movements, but passive range of motion is often normal. Okay, when active movements, that pain you can see in bursitis. Okay, so this is the things about bursitis. So next we are going to discuss about greater trochanteric pain syndrome. Okay, GTPS or trochanteric bursitis also we can call this thing. One classic example is greater trochanteric pain syndrome or GTPS. It's not true bursitis alone. It's an overuse syndrome of the gluteus medius and gluteus minimus tendons running over the greater trochanter. If you are seeing this image, you can see here, this is piriformis muscle and this is gluteus medius muscle. In between you can see deep trochanteric bursa, and before the iliotibial band you can see inside superficial trochanteric bursa. Okay, so it's not true bursitis alone. It's like because of overuse syndrome, like overuse of repetitive movements of gluteus medius and gluteus minimus tendons running over the greater trochanter. So what are the clinical features? You can see here, this is a deep trochanter, it's like inflamed, that's why it's in red in color, and this is gluteus minimus. In gluteus minimus you can see in gluteus minimus and this gluteus medius, in this both between you can see deep trochanteric bursa. So while doing overuse of movement, that bursa will get friction and it will cause and it will lead to inflammation. Okay, so that's why we call that is greater trochanteric pain syndrome. Okay, or it's like bursitis. So what are the clinical features you can see in this patient? So first one, lateral hip pain, chronic lateral hip pain, and like climbing stairs or lying on the affected side, and you can see tenderness over the greater trochanter, and pain may worsen with abduction. So when that patient is doing abduction movement of the hip, that time that pain will aggravates. Okay, and we can see local tenderness in physical examination. So in treatment, what are the things we can do in this greater trochanteric pain syndrome? Means what are the treatment we can do? Means like local heat and activity modification, and NSAIDs like heat and activity modification and physiotherapy, and sometimes so it's in severe cases we can use corticosteroid injections, helps if symptoms are persist. Okay. So next we are going to discuss about pre-patellar bursitis, also known as housemaid's knee. Let's look to another type of pre-patellar bursitis, also known as housemaid's knee, caused by repetitive kneeling in jobs like carpet laying or plumbing. If you are seeing this image, you can see here this housemaid is cleaning, like cleaning like this. When this housemaid is cleaning like this, total body weight will comes on patella. So in pre-patella, you can see because of this repetitive kneeling in jobs like housemaid job, carpet laying or plumbing, these patients are more prone to get this type of pre-patellar bursitis. Why? If you are seeing this lateral knee, you can see here this is suprapatellar bursa and this quadriceps femoris tendon in this is patellar bone, right? In front of patellar bone you can see subcutaneous pre-patellar bursa. So here if patient is always putting weight on this bursa will get bulge, or it will spread to inside, and it will cause inflammation also. So that's why we call that is pre-patellar bursitis. So what are the features you can see in this patient? First one, anterior knee pain, okay, and swelling and redness and tenderness. Okay, ankle knee pain, you can see here tenderness, erythema, localized swellings. Okay, so the pre-patellar bursa is between the skin and patella. We can see this thing may be septic, especially due to staph aureus, So how we can diagnose this thing? We have, if it's this bursa is via penetrating trauma or repetitive friction or extension from local cellulitis, we can see these things. So how we can diagnose this thing? We can confirm by aspiration bursal fluid for cell count and gram stain. So we have to draw, we have to take some we have to do aspirating of bursal fluid, and we have to send for lab and cell count and gram stain. So how we can manage this for with this patient? Okay, if non-infectious, then we can start with price treatment like protective, rest, ice applying, compression and elevation. Okay, and for pain we can give like NSAIDs. Okay, if septic, we can drainage the systemic, we can drainage that fluid, and we can use normal saline to clean. Then after we have to use systemic antibiotics. Okay, so this is the treatment for pre-patellar bursitis. Next we are going to see the Baker's cyst. So this Baker's cyst means a swelling behind the knee. You can see here, this is the lateral view of knee. Here in behind the knee, that means posterior region, we can see Baker's cyst. It's like why this Baker's cyst is forms a swelling behind the knee. Why this thing happening means it's like popliteal cyst, also known as popliteal cyst, caused by excess synovial fluid escaping into the gastrocnemius muscle or semi-membranous bursa. Okay, so causes, what are the causes? You can see with this Baker's cyst means associated with arthritis, either osteoarthritis or rheumatoid arthritis. So it's common in middle-aged to older patients. So what are the signs and symptoms you can see? It's like often painless swelling and behind the knee, and more visible in extension and less in flexion, and its rupture can mimic deep venous thrombosis, pain and swelling in the calf. Okay, so don't be confused with DVT and Baker cyst. Okay, so for diagnosis we have to do ultrasound. Ultrasound is key, rules out of DVT and confirms the cyst. You can see this image, okay, in ultrasound. Next we are going to see the patellar fracture. In this patellar fracture, like this is the last thing we have to cover, patellar fracture. We have to must know this injury because the patella is like a sesamoid bone, okay, large sesamoid bone, and it's embedded in the quadriceps tendon, and it improves knee extension and protects the joint. Okay, it will help for it improve the knee extension and protects for a direct injury, and it improves nourishment of the distal femoral reticular cartilage. Okay, so this quadriceps tendon inserts at the superior pole of the patella and wraps distally around the patella to become the patellar tendon, which inserts at the tibial tuberosity. You can see this image. This quadriceps muscle, the quadriceps tendon is directly attaching the to patella. Okay, then after you can see here patellar tendon. So why this is important means it improves the knee extension and it protects the joint. Next one, what are the causes? We can see direct trauma. If like a fall or car accident, the people is very prone to get this patellar fracture, and like indirect trauma also, like sudden contraction of the quadriceps, example landing hard on the feet. Okay, so what are the clinical signs? We can see in clinical signs. In clinical signs we can see like anterior knee pain and swelling, and inability to extend the knee against the gravity, and a palpable defect in the extensor mechanism. For management we can do like we can confirm this thing with X-ray, because you can see this lateral view of X-ray, you can that patellar bone we got fracture. And for management we have to do surgical fixation may be needed for the displaced fracture. If it's not displaced, we can use some cast and these things. So finally I'm going to give some rapid review or recap. If in bursitis, that inflamed bursa and pain with active motion, so this is the main point for bursitis. Like great trochanteric pain syndrome, like lateral hip pain, and treat with conservative management we can do for treating. And pre-patellar bursitis, watch for we have to watch for infection. For Baker cyst, it's like present behind the knee swelling, and for confirmation, for finalizing that Baker cyst, we have to do ultrasound and we have to rule out the DVT. And patellar fracture, inability to extend the knee. So if this video is helped you, please like, share and subscribe. We will meet in our next episode, that is episode 16. In that episode we are discussing about ankle joint and neurovascular anatomy things we are going to discuss in episode 16. Okay, so till that time, take care, bye bye. We will meet in our next video.